So this is case study 6. The reason for Aiden's visit, Aiden is an 8-year-old boy following up for an ADHD evaluation. His parents' concern include Aiden struggling in school and having difficulty sitting still in class. He gets in trouble for being loud and disruptive. He needs multiple reminders to stay on task and has turned in multiple assignments late. He also struggles with paying attention, staying on task, listening, and being disruptive in basketball, church group, and at home. The pediatric symptoms checklist was completed at the time of his last visit and indicated further assessment was necessary. His social history and habits include Aiden living at home with his parents and sister. He has 2 good friends at school that he likes. He sleeps 8 to 9 hours a night and denies problems. Parents deny any new stressors at home. Parents try to limit screen time usage as well. His past medical history, family history, and review systems. Aiden is generally a healthy young boy with no medical issues beyond the current concerns of his parents. When asked if anyone in the family has had similar experiences, it is mentioned that Aiden's father, who's 38, reports difficulty concentrating and being high energy, but has never been evaluated for ADHD. Events since last visit include the parents were given the Vanderbilt ADHD rating scale to be completed by themselves and 2 teachers. The results show the parents and 1 teacher's scale showing ADHD combined inattentive and hyperactivity, and the 2nd teacher's scale showing predominantly inattentive subtype. Aiden's medications include a multivitamin and Tylenol and ibuprofen as needed. His physical exam was unremarkable for any acute distress, besides noted fidgeting throughout the interview, and he interrupts during assessment multiple times. There were no labs or imaging done. However, I would want to get a baseline height, weight, and vitals. It is also prudent to get a baseline of the patient's appetite, sleep habits, if they have any headaches or GI issues, and their baseline mood. Differential diagnoses include learning disabilities or language disorders, anxiety, depression, oppositional defiant disorder, thyroid dysfunction. Some less likely differentials based on history include sleep disorders, sensory processing disorders, trauma or stress, autism spectrum disorder, or bipolar disorder. However, based on the Vanderbilt ADHD rating scales submitted and the history provided, Aiden meets the DSM-5 criteria for the diagnosis of ADHD combined inattentive and hyperactivity. So my treatment recommendation would be methylphenidate long-acting or Ritalin long-acting, starting at the lowest dose of 10 milligrams daily in the morning with food. These capsules may be swallowed whole or opened and sprinkled over food, which can be helpful if Aiden cannot swallow pills easily. In conjunction with this would be a recommendation for cognitive behavioral therapy, as well as an IEP at school, or at least informing teachers and coaches of the diagnosis and how best to support Aiden. The follow-up recommended would be in 2 weeks to evaluate progress and determine if an increase is needed in the medication. Some side effects to note include appetite suppression, insomnia, stomach pains, headaches, irritability, increased blood pressure or heart rate, dry mouth, dizziness, especially with during activity, emotional bluntness, and growth suppression in the long term. Some education to be provided is, although you can open the capsules, do not crush them. The medication should begin working in 30 to 45 minutes and continue working 8 to 12 hours. If a dose is missed, depending on the time of day, it is okay to skip that dose to prevent sleep disturbances if taken too late. And do not take extra doses to make up for missed doses. Do not share the medication and store the medication in a safe place. Monitor for the side effects. To minimize these side effects, you can take the medication in the morning with food, continue a well-balanced diet, stay hydrated, and maintain good sleep habits. My rationale for this treatment regimen is the American Academy of Pediatrics recommends medication as the first-line treatment, which is a quality A recommendation, in conjunction with behavioral therapy, which is a quality B recommendation. It is also recommended the school as part of any treatment plan. There is evidence to support using stimulants, given their quick onset and safety and efficacy profile. The most well-tolerated for this age group has been shown to be methylphenidate. The lowest possible dose to control symptoms is always the goal, which is why I chose to start at 10 milligrams. Although it is not recommended to dose based on weight, UpToDate notes that control of noticeable symptoms generally occurs between 0.3 and 0.6 milligrams per kilogram. We were not given Aiden's weight, but that would be something I would want to consider when titrating his dose. I did toy with the idea of starting with short-acting methylphenidate. However, children who require this medication to last longer than 4 hours, longer acting formulation is preferred. Given Aiden is in 3rd grade, he does require symptom management for longer than 4 hours and would otherwise need to leave class to go to the nurse's office to take additional doses of short-acting medication midday, which can be stigmatizing, inconvenient, and lead to missed doses. These medications can be titrated as often as every 5 to 7 days. Therefore, a follow-up in 2 weeks should be enough time to evaluate efficacy of dose and make sure the side effects are manageable. While trying to find the right dose for Aiden, I want to keep a close eye on him. However, after therapeutic doses identified, follow-ups can be extended to every 3 months.